Morning to all of you. Uh, I'm very passionate about this. The GIP and GLP-1 receptor agonist, and the new kid in the block is the terzepatide, the Mounjaro. We are all quite excited about this molecule. During the course of my discussion, I'll be taking you through the incretin hormones, presence of receptors in the body, the therapeutic approach, the mechanism of action, and the weight management and the safety profile and FDA approvals. Non-disclaimer, only few slides have been taken from the Eli Lilly, and thanks to them I acknowledge it. Well, according to the WHO, the obesity is one of the most common yet most neglected public health problem in both the developing and the developed countries, and India has the third highest obese population in the world. WHO has already actually recognized it as a disease long time back in 1948, and in 1997 it has been given in the category of the global health problem. We all know it's the abnormal and excessive accumulation of the adiposity, which presents it as a risk of health. So obesity is a disease. Obesity is not good in look, it is not being healthy, it is a disease. So when does it become a disease? It is defined when the BMI is more than 30 more than 30. It is categorized into 3 classes. Before that, we understand for the Asian, our normal BMI is 22 to 26. Between 26 to 29.9 is the overweight, and beyond 30 to 34.9 is class 1 obesity, 35 to 39.9 is class 2 obesity, and more than 40 is class 3 obesity. This is such a chronic disease, though of course it is because of dysfunctional adiposity, that the person doesn't realize that he is getting the problem. Because it is chronic, it is every day, we get so used to it, we don't realize when the same problem becomes a disease for us. And prevalence is across the globe, and many obesity related complications, because of obesity, they will almost get cured and preventive with the weight loss. So what are the causes? It is very multifactorial. We know mainly it is the in and the out. Intake is the food, the environmental factors, our habits, and out is how much you exercise, how much you become active, how good is your metabolism. So it is an acute balance between both of them. And factors like socio-cultural, what are your sleeping times, what are your waking times, how much you party, the environmental factors, the epigenetic, the genetic factors, which are very important, which you can't help. But there are others, like physiological, like behavioral. Behavioral, why? Because it's a mind-gut axis. Whatever is in your mind and whatever you put into your gut actually goes into your mind. It is completely a mind-gut axis which works. And it is the behavior of the person, how to eat, when to eat, what to eat. That realization is extremely important. Coming to the epidemiology, it is estimated that from 2010, the cases are rising from 511 million, and they are expected to extrapolate by 2030 to 1025 million cases. And in US, the magenta color, which is seen across, it is getting more and more. This is the prevalence which is going to be there till 2030. And in India, we are in a crisis of obesity now. We have always said health is the greatest wealth. We say wealth is lost, nothing is lost. Health is lost, everything is lost. And as obesity emerges as a silent epidemic, with no hue and cry, it's not like COVID that everybody knows about it because it is so chronic. and it is again like as silent as diabetes and hypertension, and now it cuts across all the socioeconomic groups. It was earlier confined to the affluent section of the society, but now it affects 24% of women and 23% of men. And what has happened? It is driven by the urbanization, by the sedentary lifestyle and unhealthy diets. The World Obesity Atlas 2023 warns that by 2030, over 163 million Indians could be obese and posing a grave health, social and economic challenges. And tackling obesity is not just a health necessity, but a step towards realizing the vision of Sarvshresht Bharat and a healthier, productive Viksit Bharat by 2047. Well, obesity, we all know, is a multi-system disease and is associated with comorbidities. I know all of you are aware of the problems which the obesity causes in every system of our body. Just let's go through it. What does it do? What does it do to the neurological and psychological? There is increased incidence of stroke. There is increased incidence of diabetes mellitus, diabetic retinopathy, diabetic neuropathy, pseudotumor cerebri, dementia, depression, anxiety, binge eating, migraine, social stigmatization, and cardiovascular. Of course, incidence of hypertension rises, heart diseases, coronary artery disease, peripheral artery disease, atrial fibrillation, heart attack, congestive cardiac failure, high lipids, as we have been studying since morning, poor circulation, venous stasis in the legs, thromboembolism and blood clots. And because there are clots in the peripheral veins, the incidence of pulmonary thromboembolism and sudden deaths suddenly rises. Not to leave the genitourinary involvement in the woman, we all these days now, there's like every woman, most of them are, we talk about PCOS, the reduced fertility, the urinary stress incontinence, the irregular periods, the pregnancy complications. In men also there is reduced fertility and erectile dysfunction. And in the lungs, obstructive sleep apnea, which is so much a huge complication, pulmonary hypertension, restrictive lung diseases and respiratory failure. In the kidneys, because the fats in the kidneys, they decrease the perfusion, they can cause CKD, nephrolithiasis, proteinuria, and of course in the GI, the NASH, the NFLD now being called as MASH, the gallbladder disease, the hepatic steatosis, and in the musculoskeletal, the severe osteoarthritis, the lower backache, the disc problems, and sarcopenia. So NASH and sarcopenia, which are the two current latest problems of the metabolic syndrome. So of course people want to lose weight. So whenever the weight is lost for a short term, it has been seen that within 2 years 50% of the weight is regained, and within 5 years more than 80% of the weight which was lost is regained, and it's like a ping pong ball. The regained weight is even higher than the weight which was lost. Well, this is the etiology. We all are familiar with this etiology. This is the intake. And now let us see what are GLP-1 and GIP receptors and what are these drugs, the coagonists. So GIP is the glucose dependent insulinotropic polypeptide, which is a hormone that is secreted from the duodenum and that binds with its receptors, the GIPR, and the G protein coupled receptor, which is found on the pancreatic beta cells, adipocytes and the bone cells. So upon binding, what happens? It signals the pancreas to produce insulin, and it promotes the fat deposition and influence the bone remodeling. So the GIP and GIPR, this system, along with the glucagon-like peptide 1 and its receptor system, They are very crucial for the metabolic health, and the therapy, which is a dual agonistic therapy like tirzepatide, it shows superior effects in managing both diabetes mellitus type 2 and obesity. So let us look at the gut pancreas axis, because both these drugs are called incretins. Well, not the incretins are both these hormones, the GIP and the GLP-1. So the gut pancreas axis is the incretin signal to the pancreas in response to the nutrient load. So when the gastric nutrient load goes to the duodenum, from the K cells the GIP is released, and when it goes into the jejunum, the GLP-1 is released to be acting on the pancreatic different cells. The glucagon cells, the pancreatic polypeptides, and the beta cells. So this load in the gut, it stimulates the release of the incretin hormones, the GIP-1 and the GLP-1, and then it enhances the glucose dependent insulin secretion, and this incretin effect is the major contributor to the regulation of the postprandial glucose clearance in the healthy people. So let us see what happens in the healthy people. The gray graph is when it is the glucose is given intravenously, and the red one is when it is nutrient load of the glucose is given. So what we are looking at, the amount of insulin production. At the same level after 1 hour, the red graph, which is because of insulin secretion because of the nutrient glucose load from the gut, is much higher. This is called the incretin effect, because when you eat, the insulin is secreted more as compared to when you give it the same load in the intravenous form. And this very incretin effect is blunted and diminished in the patients with diabetes. You are looking at the on the other side of the graph, and that is completely blunted. So this is the one, this is how the incretins, these enzymes, they work. And on the adipocytes, we all know that adipocytes are like brown and white adipocytes. The white adipocytes, they also store energy and they act as endocrine cells, because there is also representation of these receptors on the endocrine cells of the adipocytes as well. And the brown adipocytes, they generate heat through thermogenesis. Now let us see what is the mechanism of action of the tirzepatide, because as I said, the receptors are on most part of the body, in the brain, in the GI, in the liver, in the stomach, in the periphery, in the pancreas, in the CNS. So what does it do in the CNS? It decreases the appetite, it decreases the food intake, and in the liver, it decreases the fat content of the liver, it decreases the inflammation of the hepatocytes, and even it is known now for the reversal of fibrosis as well. And in the stomach, it decreases the gastric emptying, so that the food there takes little longer and the satiety remains for a longer time. And in the it acts on the pancreas by producing insulin and by decreasing the glucagon secretion, and in the periphery it acts as a insulin sensitizer. The effect on the appetite and food intake is so great that many of the patients, they really say we don't feel like eating anything, and they don't feel like taking alcohol. Somebody who's been binging on alcohol, they say, oh, I don't feel like taking alcohol at all. And somebody who's a smoker, they even stop smoking. One of my patients was on the drug, he was getting a very good result of a diabetes, he was obese, and I saw he was not coming for 1 or 2 months. 3 months later, he landed up with the Department of Orthopedics with a broken fibula, tibia fibula. So he came to me for the medical clearance. I said, what happened? We were giving you the drug and you were doing so well. He says, वो शराब पीने को दिल ही नहीं करता था फिर, तो मेरे को शराब पीनी थी इसलिए मैंने वो छोड़ दी. So it is the other way around as well, because the effect is so great that you don't feel like taking alcohol. So it is, that such a great effect of the drug is there that the patients absolutely don't feel like taking it. So this terzepatide as a single molecule, it activates both the GIPR and GLP-1 receptors. As compared to the native GIP, it is almost the same, but the potency of terzepatide as compared to GLP-1 native receptor is slightly weaker. This is the molecular structure and the property that this is a long-acting GIP and GLP-1 receptor agonist. What makes it a long-acting is the albumin binding. It is bound to the albumin, so that the half-life of this molecule is approximately 5 days, so that it enables us to make it a once-a-week dose. And the plasma concentration in the patients with renal and hepatic impairment, they do not differ from those in the healthy people. So let us see what were the weight effects of terzepatide in phase 2b study in the type 2 diabetes. This was compared with dulaglutide, the Trulicity, which we all had been using since terzepatide has come now only. Trulicity we all have been using, that is dulaglutide. So comparing, this was how the study was conducted with the placebo with dulaglutide 1.5 milligram and various concentrations of terzepatide 1, 5, 10, 7.5 and 15. Look at the effect. The top line, with the dulaglutide, is the rounded one with the dulaglutide, the round circles. There is a weight loss along with the diabetes control, but it is only to the action of like 5%. It doesn't continue more than that. And the lowest one, the dark blue and the turquoise one, is with various doses of terzepatide, and with the 15 milligram of terzepatide, there is almost a loss of more than 25% of body weight and continuation of maintenance of the loss of body weight. So these were the clinical trials, phase 3 clinical trials. They were done with, this was the program. Surmount 1 was done for the weight management, in 2 the weight management in diabetes mellitus, 3 it was continued with intensive lifestyle, 4 with maintenance of the weight loss, and with 5th with the related comorbidities. So what we achieved was like 25% weight loss with the maximum dose of 10 to 15 milligram of terzepatide. And so same is the improvement in the BMI. So greater than 81% participants in the 15 milligram arm achieved at least minimum 5% body weight loss, and over 50% participants, they at least got 15% weight loss as a key secondary objective. So, and the impact on the maintenance of weight reduction and benefits of the continued therapy. So the therapy was continued, the benefit was continued as such. This is a very, very important trial, the Synergy NASH trial, because now is again the epidemic of our MASH cases. We are every day, all the reports from the radiology are coming, fatty liver, fibrosis, grade 1, 2, 3, 4, and we are again heading towards the, so much of liver disease burden because of the MASH is coming now. And this is again a light by the end of the tunnel, that this phase 2 clinical trial, they evaluated terzepatide for treating MASH with liver fibrosis, and there was almost complete disappearance of the inflammation of the hepatocytes and also improvement of the fibrosis at least to grade 1 or 2, like somebody having F2 could come down to F1, for F1 to F0. So with 15 milligram, there was MASH resolution in around 73% cases compared to placebo with 13%, and fibrosis improvement with 54% cases compared to 32%, and a persistent good weight loss. And even a weight loss of 5%, it improves the adiposity related complications. Name it, like whatever we named as the complication, like diabetes, hypertension, obstructive sleep apnea, osteoarthritis, dyslipidemia, metabolic syndrome, dysfunction associated, and NASH and steatohepatitis, everything improved even with the 5% weight loss. Now let us have a look at the FDA approved GLP-1 and GIP agonists and frequency of administration. We have semaglutide with Novo Nordisk once in a week injection, the Ozempic and the Wegovy. It is recommended both in diabetics and weight loss, but compared to tirzepatide, the weight loss with semaglutide is less because it stimulates only one GLP-1 receptor agonist. So while tirzepatide and the one which is oral ribelsis is effective only for diabetes, it doesn't achieve that kind of a weight loss, not recommended without diabetes. So tirzepatide by Eli Lilly, the frequency of the injection is once a week, available in India especially from 2.5 dose so that the cost can be less. Otherwise in abroad they have started only from 5 milligram, 5, 7.5, 10 and 15 milligram, so that we can gradually increase the dose according to the need of the patient. Recommended both for Mounjaro, recommended both for obesity and the tremendous weight loss, which is, I would say, it said cut down the role of bariatric surgery to almost very, very low now. So anybody who wants to go in for a bariatric surgery must be given the choice with Mounjaro. And then we had compared with, I've already shown the slide with dulaglutide. It is recommended only in diabetes. The weight loss is not that much. And the others like liraglutide, lexenatide, exenatide are actually to be administered daily. So hence that kind of things, the weight loss is not achieved with them. So the combined actions of GIP and GLP-1, it helps to maintain the metabolic balance by preventing both the hyperglycemia and hypoglycemia. And it improves the insulin sensitivity and it reduces the ectopic fat distribution. The safety, it is extremely safe. It includes only nausea, vomiting, diarrhea and some injection site reactions. And hypoglycemia risks is very, very low. Long-term safety data are still being collected. Well, this is one of our children only from relatives. I've taken his permission to show the picture. He is a radiologist. The one standing tall, 6 feet 7 inches, weighing at 158 kgs. And this is the other picture after losing 40 kgs of weight and within 4.5 months. So research is ongoing to explore the expanded indications. Cost and accessibility are still little challenges, but personalized treatment approaches, they are important to maximize the benefits and to minimize the risks. Thank you very much.